Welcome to Harlow on Healthcare. I'm David Harlow, and I invite you to join me by my virtual hearth as I sit down with healthcare leaders to discuss building the future of healthcare. Today, my guest is Andrew Mellin, VP Medical Informatics at Surescripts. Andrew is a seasoned physician executive who brings multiple perspectives to the table and is working to improve the flow of information in the world of prescriptions in order to advance the triple aim. Welcome, Andrew, and thanks for joining us.
I'm really happy to be here. Thanks for having me.
So many of us know of Surescripts as a national health information network for prescriptions. Could you put a little more color on that and briefly describe what Surescripts is, what Surescripts does these days?
Sure. As you said, Surescripts has built really an industrial-strength health information network with a goal to increase patient safety, lower the cost of healthcare, and improve the quality of care. Our solution started with prescribing and enhanced prescribing, but also informs care decisions and advanced healthcare. As part of what we do, we have formed the Surescripts Network Alliance, which includes virtually all the electronic health records, pharmacy benefit managers, pharmacies, and clinicians, plus an increasing number of health plans, long-term and post-acute care organizations, and specialty pharmacy organizations. So today at Surescripts, with our Surescripts Network Alliance, more than 85% of all prescriptions are sent electronically using our network. And overall, we processed 17.7 billion healthcare transactions in 2018.
Well, it certainly covers the waterfront in terms of the prescription activity in the States. And from that perspective, I'm wondering if you could address some of the top challenges, some of the top healthcare challenges that the company is in a position to address. I imagine this has also changed over time. I'm just wondering if you could speak to that. What are sort of core areas of focus today, and how's that different from what that's been in the past?
Sure. Surescripts started about 18 years ago with a main focus on electronic prescribing. And so we built up electronic prescribing and eligibility and formulary information for providers from the ground up. And as that's evolved and changed over time, we've broadened our focus. And today we're focused on three broad challenges in healthcare. So at the heart, we are still highly focused on making the prescribing process as efficient, safe, and reliable as possible. You know, as a physician, I certainly remember the days where I wrote a prescription on a piece of paper. I used this cryptic Latin abbreviations, and that had all kinds of issues. I had really no awareness of the person's benefits. My handwriting is frankly horrible and not very legible.
Oh, I was going to ask about that. I was hoping your handwriting was illegible.
It is not good. And when I gave that piece of paper to the patient, they had to wait at the pharmacy for it to be filled. And the other challenge was, back in the days of paper, and even in the early days of electronic medical records, when I wrote those prescriptions, the only awareness I had of that patient's medication history was the ones I personally wrote or the ones that were in the chart, paper or electronic, and the patient's recall, which we know, honestly, isn't great. They omit medications and can't remember everything. So certainly I could have missed other important medications that the patient was taking. So today, though, it's a really different picture. When the doctors write their medication in the electronic health record, the first thing is they do this with the context of a complete medication history from across the country. So we bring together that medication history from pharmacies and pharmacy benefit managers and put it right in the context of the EHR. And then when the doctor writes a prescription, it's transmitted electronically to the pharmacy, so it's ready to arrive. Certainly don't have to read my handwriting anymore. And it's there waiting for the patient. So now, even though, like I said, most prescriptions, a large majority of prescriptions are written electronically, there's still some work to be done. And we're working with our network alliance to hone in on eliminating any chance of ambiguity or any other inefficiencies that occur in the electronic prescribing process, which really lead to phone calls from the pharmacist back to the office and delays in care. And I'm really proud of the work we've done in the past year where we've improved the prescription quality about 14%. I'll talk a little bit more about that.
So when you say improved quality, what do you mean exactly?
Sure. So we have developed a number of metrics with our network alliance that look at various aspects of what constitutes a high quality prescription. making sure the name and the codes match, making sure there's a consistent name that's been agreed upon by sort of this network as the best way to transmit the information, making sure that the HR is using that, making sure that the alliance has adopted some other aspects of the transaction, of the prescribing transaction, some newer ones that, for example, send cancel and change messages between the pharmacies and the provider. So we have built a way to measure this with our network, and so we're continuing to march down that path of checking off and improving that transaction and making sure we remove any ambiguity from the prescribing process.
I'd like to ask you, you mentioned something about getting information, collating information about multiple prescriptions across providers through the network. One question I have there is whether your system, your network, is applying any intelligence to that to look at drug interactions or contraindications, things like that.
Sure. So today, we generally leave the intelligence around drug interactions, contraindications, et cetera, to the health technology vendors that are the recipients. So most pharmacy systems, all pharmacy systems and all EHRs have capabilities around that. They work with a number of compendium and provider organizations to tune those. So we transmit the information, we do some quality work on that information, but the actual decision support, like you described, is really left to the EHR vendors and the pharmacy technology vendors. So another area that we're focused on is around interoperability between providers. And certainly this is something that everyone in the country, everyone in health IT is talking about. So we play a large role in many health systems and provider organizations when they exchange clinical information. And let me share sort of one unique aspect of that. We have a service that when the patient gives us permission or gives their provider permission, allows us to search across the country to identify their encounters and to retrieve clinical documents within a different number of EHRs. So this is all done as a part of Care Equality, where we're a founding member, and they provided a trusted framework to allow this type of interoperability for care and treatment of the patients. So we bring that framework to life with a technology that does this record locator and exchange. So without this, what happens is that most EHRs do have interoperability capabilities, but typically they're limited to either finding records from other users of the same electronic health record, or maybe only finding records from a local health system. Or you might have to know a very specific address of another provider to retrieve that information. We make it really easy. So within that EHR workflow, as they look for records for a patient, we will go across the country and identify all the other locations, or most of the other locations where that patient has had an encounter. So it's really exciting. And I think for me as a provider, what's most fun about this and what's most rewarding is some of the great stories we're hearing about this. And I'll just share one. This was one as an internist I really wasn't even aware of would happen. So one of the challenges on transplant patients is they often hide information. They don't want to tell an organization that's going to do their transplant about some of their other conditions because they really want the transplant. They don't want to give any reason to not get it done. So one health system was relaying this story to us where a patient came to them, they needed a transplant, and they just omitted a very serious coagulation condition that had been treated in a distant state. So when they went into the EHR and used our record locator service, they saw that this person had a number of encounters in a distant state. They pulled up that information and they realized that she had a hypercoagulable condition. She was prone to getting blood clots. So they did go ahead with the transplant, but with this knowledge, they obviously had to do a number of additional treatments to prevent those clots from happening. Again, this is a great example where that information led to a very significant change in care, where a transplant likely would have failed or had significant complications if that provider organization wasn't aware of that information. So lots of stories like that about having that information, being able to retrieve it across the country truly makes a difference in healthcare.
Sure, that's very important. You mentioned the Care Quality Initiative and how that is going to interact, or do you expect it to change as a result of the next stage in the development of the TEFCA trust framework?
Yeah, I mean, I think that's still being developed, and there's still changes. The final law isn't in place yet. I'm sure there will be some changes. What exactly that will be, I'm not sure. I mean, care equality as it is created this great framework that members can join and freely exchange information between each other from a legal perspective. And it's something that has created a great process or great progress in interoperability today. How it will change under TEFCA, I don't know.
Yeah, I know there's been a couple of rounds of public comment and still hasn't been finalized. From my perspective, I just think it's hard to change the facts on the ground, sort of after the fact, now that care quality and common health have both been implemented and connected, and we'll see what happens as that process continues with TEFCA.
Yeah, we are obviously monitoring that very closely and educating the government where we see appropriate.
So you've described some challenges and some challenges that have been solved is too strong a word, but certainly addressed in a way that hasn't been possible in the past. There are obviously more problems ahead, more problems to solve ahead. One in particular that's top of mind for many people today is the opioid crisis. And I'm wondering if you can speak to ways in which Surescripts may be working together with states or other actors to address the opioid crisis.
Yeah, the opioid crisis is really complex, and there's not a magic solution that's going to solve everything. That said, we do play a leading role in a number of different areas, and let me talk about sort of three. First of all is what's called an electronic prescribing of controlled substances. So that allows that prescription to be transmitted from the electronic health record to the pharmacy electronically. And today, 95% of pharmacies are enabled for this, and 32% of providers are enabled. And why is this so important? I think if any provider has either heard stories or been personally affected where a prescription was forged using that provider's DEA number, or a patient altered a prescription, maybe changing a number 10 to a number 40. And so with electronic prescribing of controlled substances, that prescription is sent right from the EHR to the pharmacy system using additional levels of security and ID proofing. So that really limits the opportunity, or virtually eliminates the opportunity, for prescription alteration, forgery, diversion, even things like pharmacy shopping, where a person might take a paper prescription pharmacy to pharmacy to find one that would accept a fraudulent script. So, and why this is important is up to 9% of diverted drugs for abuse are tied to fraud and forgery of paper prescriptions. So a lot of progress there. I think the second area is around medication history, and we talked about that earlier, but this is also important in the opioid crisis. So today, most states have enacted a prescription drug monitoring program, and there's usually a technology solution that lives outside of the EHR workflow, and often and usually only contains information from that state or region. So what we deliver today is, through that medication history service, is the ability to retrieve information for 90% of patients from across the country, from both the pharmacies and the pharmacy benefit managers. So within the EHR workflow, within the context of other medications, they're seeing the opioid dispensing history, they're seeing the authorizing provider, where it was dispensed, and the original prescription details. So they don't have to leave their EHR workflow to get that information. So that medication history is an important complement to the prescription drug monitoring programs. And then, as I think you alluded to, we've done a lot of work in educating the clinical leaders and the state and national government bodies about the things that we can help with and the importance of electronic prescribing of controlled substances, and really the most effective and efficient ways to incorporate and mandate this for the prescribers and pharmacy workflows. So states like New York have mandated electronic prescribing of controlled substances, and there 85% of controlled substances are prescribed electronically. There's still the ability to use paper prescriptions in emergencies and sort of certain situations, but by and large, they're all being done electronically. Overall, across the country, that growth of electronic prescribing of controlled substances has gone from 11% 2 years ago to 32% last year. And we expect it to really grow rapidly with the number of state mandates that are enacted. So in 2018, eight more states passed mandates, and there are now 15 total states that have electronic prescribing of controlled substance mandates.
If you're just tuning in, this is Harlow on Healthcare, coming to you on HealthcareNOW Radio. I'm David Harlow, and my guest today is Andrew Mellin, VP of Medical Informatics at Surescripts. Andrew, it's interesting as you're talking about the growth in the use of electronic prescriptions for controlled substances, that it seems that only a few years ago that was prohibited in many states rather than mandated. So it's an interesting evolution and recognition of the maturity of these platforms.
Yeah, that's right. I think from a technology perspective, we're there. There's that part is solved. Now it's just helping various state legislatures understand how it works, how to incorporate in the providers' workflows, how to make sure there are appropriate exceptions, and really what the impact is on the overall opioid crisis. So there's activity in almost every state that hasn't done something already. And in the next few years, we see this being very widespread.
So stepping back and looking at the landscape more broadly, we're approaching a point in time where through networks such as some of the ones that you've described, there's greater interoperability from provider to provider, from system to system. And I'm wondering whether in this age of interoperability, if you see an opportunity or a chance for local organizations rather than a single national organization such as Surescripts to be collaborating together and promoting some of the efforts that you've been working on. Is there a need for a central single organization, or are we at a point where we can use a network? I mean, what are sort of the pros and cons to those two solutions to this problem?
Yeah, and so we don't think of ourselves as a standalone company. We see ourselves more as a facilitator of a network alliance, which I described earlier with EHRs, PBMs, pharmacies, clinicians, and many others. And they all work with us and they work together to help us realize our collective purpose to serve the nation with the most trusted and capable healthcare information network. And to that point, we've served more than 258 million patients and 1.6 million healthcare professionals. So the way that we operate is this network brings us key challenges in healthcare that they can't solve alone. And all these challenges depend on 2 or even 3 different kinds of stakeholders collaborating together to improve the experience, cost, quality, and safety for patients. So we take on these really hard problems and we take on the long view. Now, all that said, I mean, we do work very closely with the standards bodies. So we play a major role in standards development and stewardship with the NCPDP and HL7. We're founding members of Care Equality, as I mentioned, and we participate in Direct Trust and Sequoia. And so there's the standards, and then there's bringing those standards to life. And I've been in healthcare a long time, and I think all of us know and have seen that there are standards, and then there's the real world, right? So
Right.
There's what the standards bodies do, which are great and are critical to helping drive adoption. But then it's the hard work of bringing the different stakeholders together and bringing this to life in a way that makes it easy for those stakeholders to interact across a broad network of pharmacies and providers and PBMs. I'm going to share 2 examples of this. The first one I want to talk about is sort of just how we catalyze and drive adoptions of brand new solutions across this network. Places where there are no standards and places where there are hard problems. So one area that we've been focused on in our network has been focused on is medication cost. So about 4 or 5 years ago, our network alliance came to us and said, we need to create a solution, to focus on the rising cost of medications. And one way to do that is bring the cost, that patient out-of-pocket cost, and more affordable alternatives right to the point of care when the provider's prescribing. That information has never been available before. So when they came to us, there were no standards. None of the EHR systems or pharmacy benefit managers really had capability to support this. So it was a great idea, but at that time, there was no way to do this. So we worked, again, across multiple sides of that network to come together and develop a brand new novel real-time decision support capability really unlike anyone I've ever seen before in health IT. And so here's how it works. As soon as a provider in their EHR enters enough information to specify what that prescription would be, that EHR immediately sends us a transaction, that information, and we determine which, we understand from that who is that patient's benefit provider, who's their pharmacy benefit manager insurer. We route that to them, and in their systems, they go ahead and determine the cost, that out-of-pocket cost for the patient. They also present, where appropriate, alternative maybe drugs that are in the same therapeutic class, or alternative quantities, or alternative dispensing locations like a mail order pharmacy. They send it back to us, and we communicate back with the EHR. So that process takes generally like a second. So that was something that we pioneered. We were able to help develop the process and the approaches to do that. And so what's really exciting for me is about how these EHR partners have incorporated this into the provider's workflow and really make it easy for them to choose the alternatives to do the right thing for the patient. So we pioneered that, and now that transaction is becoming a standard by the NCPDP. So, that standard wasn't there. Now it's becoming a standard based on a lot of the work that we've done in our network. But it took someone like us to bring the parties together, develop the models and approaches to doing this when none existed, and support, building that initial critical mass of adoption across many stakeholders of the network. And we've seen tremendous adoption. There's about 140,000 providers, starting with virtually zero at the beginning of 2018, that are using this today. We're seeing cost savings ranging from $47 when an internist changes a medication to the patient, to $228 to psychiatrists when they choose different drugs, to even an example where one patient saved $8,000 by going from the retail pharmacy to a mail order pharmacy for a specialty drug. And it's a decision support tool that providers are really excited about. They've always known how important cost was, because if they don't get it right, the patient's not going to fill their drug, or it's going to cause rework on their side. Now they feel like they're empowered to be a partner with the patient in that economic discussion, and seeing a win for everyone in that stakeholder network. So I think that's one example of how we help.
That's great. Have you seen any follow-up in terms of adherence following implementation of the system?
It's still too early. Certainly, there have been plenty of studies out there that correlate cost to adherence.
Right.
One I saw showed that a drug over $50 with a $50 copay has a 4.7 times higher abandonment rate compared to a drug with $0 copay. But I think we want to look at that, but it's just still too early.
Andrew, if you were to wake up tomorrow and find yourself 5 years in the future, what is one thing in healthcare that you would hope or maybe expect to be radically different from the way it is today?
Yeah, I think one area I'm really focused on being a provider is physician burnout. And I think we've all probably seen the statistics that about half of providers feel like they're burned out. And this is due to administrative burdens, feelings of loss of autonomy, and many, many other factors. And so really in 5 years, I hope this burnout level is dramatically lower. And I don't have these conversations with my colleagues and providers across the country. And now they're talking about the joy in their work, not the frustrations and challenges, and even thoughts of looking for other professions. And so there's no magic way to solve this problem. There's many, many factors contributing to this. But I know part of the solution, and the part that I'm focused on and we're focused on, is using technologies like the EHR to decrease a lot of those administrative burdens. There's just frustration. For example, like I talked about, when the pharmacy calls back and says, Dr. Mellin, this medication you prescribed is okay, but that patient maybe can save $50 if you switch to another one. That's just rework for me. That's, my mind has already moved on to 20 other things. That's just waste in the process and a bad experience for me, my office staff, and the patient. There's a lot of administrative tasks like prior authorizations that we're working hard to automate and make much, much less onerous. So that information needed to complete those can be done with minimal interventions and just by drawing out other information from the EHR. And I think there'll be other technologies that continue to eliminate, remove, minimize a lot of the other sort of non-clinical activities that just weigh on the shoulders of the providers and their staff and take a lot of their time. And I also see the HR just being a key factor in reducing that cognitive burden on providers. Today, it's just overwhelming for providers to assimilate and understand all the patient's information, remain up to date and comply with all the relevant evidence-based guidelines, and identify the critical elements out of all that inform a diagnosis or change in therapy in 15 minutes. So what I'm starting to see and what I'm excited about is some interesting solutions where all this information, the clinical information, critical insights through artificial intelligence and other ways, decision support tools, and knowledge from external sources are all presented together in novel user experiences that ensures the provider is delivering high quality and patient-centric care as efficiently as possible. So I hope we've made a huge dent in this challenge with provider burnout.
Yeah, there's certainly such information and data overload, and hopefully some of the tools and approaches that you're talking about will help to filter that and improve not only the workflow, but the provider experience. Thank you for joining us today. I appreciate your taking the time to be on Harlow on Healthcare, Andrew.
Thank you, and appreciate the opportunity to talk with you today.
You have been listening to Harlow on Healthcare. Join us at HealthcareNOW Radio.com. Let's continue the conversation on building the future of healthcare together at #HarlowOnHC. I'm David Harlow, keeping the fire going and holding a seat open for you. Until next time.